The United College Distinguished Visiting Scholar Scheme is made possible through the generous support of the college's endowment fund. Under the scheme, United College is able to invite internationally renowned scholars to Hong Kong to give public lectures and to meet staff and students from the college and the university. United College is very honored to have invited Professor Andrew T. Chan from Harvard Medical School as our Distinguished Visiting Scholar this year. Without further ado, I would like to pass over the floor to the moderator of today's lecture, Professor Martin Wong. Professor Wong is from the Jockey Club School of Public Health and Primary Care, and he is also the Associate College Head and Dean of Students of United College. May I now invite Professor Wong on stage to introduce Professor Chan and the topic of today's afternoon. Professor Wong, please.
Okay, thank you very much. Dear Professor Stephen Wong, Professor K.P. Fung, Professor Helen Meng, and also Professor Bruce Lee and Professor Tang, Tony, and all colleagues, ladies and gentlemen, students, and our very good friends. It's indeed a very great pleasure and a very great honor for me to introduce Professor Andrew T. Chan, the Distinguished Visiting Scholar of the United College in the year 2023-24. Professor Chan is an exceptional figure in the field of gastroenterology and cancer prevention, and we are privileged to have him as our distinguished scholar this year. Professor Chan's impressive list of credentials and accomplishments truly speaks for itself. As the Daniel K. Podolsky Professor of Medicine at Harvard Medical School, Professor of Immunology and Infectious Diseases at the Harvard T.H. Chan School of Public Health, and Chief of the Clinical and Translational Epidemiology Unit at the Massachusetts General Hospital, his expertise is renowned globally. Furthermore, he serves as the Director of Epidemiology at the MGH Cancer Center and co-leader of the Cancer Epidemiology Program of the Dana-Farber Harvard Cancer Center. Professor Chan's contributions to the medical field have been recognized through his membership in prestigious societies, such as the American Society for Clinical Investigation and the Association of American Physicians, as well as his appointment as an American Cancer Society Clinical Research Professor. Through his career, Professor Chan has dedicated his research efforts to preventing colorectal cancer by preventive drugs and lifestyle interventions. His groundbreaking work encompasses the epidemiology of the gut microbiome, gastrointestinal bleeding, inflammatory bowel disease, and gallstone diseases. The impact of his research extends far beyond publications, significantly influencing clinical practices and benefiting countless patients worldwide. It's also worth noting that Professor Chan's outstanding contributions in cancer prevention have not gone unnoticed. In the year 2021, he was recognized as one of the 50 change makers in cancer prevention by the National Cancer Institute. And in 2022, he was honored as an American Cancer Society Clinical Research Professor, which is the highest distinction bestowed by the foundation, acknowledging his pioneering work and exceptional mentorship. In addition to his research endeavors, Professor Chan has displayed extremely excellent leadership skills by mentoring over 30 investigators who now have become independent faculty members with their own extramural funding. He has also played a pivotal role in developing evidence-based clinical practice guidelines in gastroenterology. As a clinician, Professor Chan provides comprehensive care in general gastroenterology and specializes in endoscopy for patients with high-risk cancer genetic syndromes. So during this visit, we are very pleased to announce that Professor Chan will deliver 2 insightful lectures as part of our Distinguished Visiting Scholar Lecture Series, and the committee being chaired by Professor Helen Meng. In today's first lecture, Professor Andrew Chan will discuss the current landscape of cancer prevention. Traditional approaches such as early detection and unselected chemoprevention face limitations and have in fact yielded few successes. However, aspirin has shown to be a consistent medication that has evidence to support its reduction in terms of colorectal cancer incidence, leading to population-wide recommendation now. Nevertheless, recent data highlighting individual differences in the effects of aspirin underscore the need for precision medicine in cancer prevention. Professor Chen explores the application of genetic epidemiology and translational studies to translate the promise of precision medicine into effective cancer prevention strategies. So on behalf of the faculty and the students of United College and the Chinese University of Hong Kong, we extend our warmest welcome to Professor Andrew T. Chen. And may we now invite Professor Chen to deliver the lecture entitled Aspirin and Prevention of Cancer. Professor Chen, please.
Thank you, Professor Wong, and thank you very much to Professor Stephen Wong as head of the college and the committee for selecting me to provide this lecture and also to have the opportunity to be the visiting scholar. It's deeply humbling to be invited in such a capacity. As I've told many of my guests, some of my hosts today, Chinese University of Hong Kong has a very special place in my heart. I actually spent a significant amount of time here as a medical student. At Harvard, I spent almost a year here in Hong Kong conducting cancer research at the Prince of Wales Hospital. And that was where I really began to have a significant interest in research. And that's really where my desire to become a physician scientist was born. So it's really wonderful to have this opportunity to come back to Hong Kong and to be able to share with you some of our work in cancer prevention. So as has already been mentioned, I'm a gastroenterologist. I'm also an epidemiologist. So my training is in epidemiology and the use of epidemiology to develop insights into clinical medicine and to develop opportunities for clinical translation. So these are some of the disclosures in my work, and this is what I hope to accomplish in the next hour or so of my lecture. I will talk about aspirin and colorectal cancer prevention with a focus on recent data to understand the role of aspirin for cancer prevention, particularly understanding that there might be differences in the effective age on aspirin's effect on colon cancer. I'll then go into depth about some potential biomarkers that may be useful for the clinic to understand who will be potential candidates for aspirin treatment for prevention. I'm also going to present some new data on the ability of aspirin to potentially prevent other cancers, particularly liver cancer, and also metabolic dysfunction-associated liver disease, which is a growing cause of liver disease in the United States, but also all over the world. And finally, talk a little bit about the effect of aspirin on bleeding. So hopefully I'll be able to give you insights into these multiple dimensions of the effect of aspirin, which is truly, in many ways, a wonder drug. So to first talk about aspirin and colorectal cancer, I want to basically go through the weight of evidence that really supports the fact that aspirin as a drug is effective in prevention of cancer. And I think it's important to understand why this is so important. Colorectal cancer is a leading cause of cancer death around the world. In Hong Kong, it's the second leading cause of cancer death. And we really need to think about strategies for prevention because, as many of you may know, who may have had a family member or may know individuals that have been affected by colorectal cancer, when colorectal cancer is diagnosed late, it is fatal, universally fatal, and also a very difficult disease for patients to succumb to. So we really need to think about strategies for prevention and think about strategies that are also potentially economical, particularly in resource-limited settings where there really are challenges in terms of being able to resource things like screening programs. And although there have been successes in prevention of colorectal cancer through screening, many parts of the world are unable to use screening and be able to leverage screening across a large population. So aspirin is particularly attractive because it is a drug that's been available for over 125 years and is a drug which clinicians are very familiar with using. It's widely used for many different conditions, including pain control, but also it's been useful in the field of cardiovascular medicine. So there's a lot of use of aspirin for the prevention of heart attacks in people that have a history of heart disease. So we are very familiar with that as a drug. So being able to repurpose this commonly used drug for another indication, in particular cancer prevention, is a very attractive modality. So why do we think aspirin has its effect on cancer prevention? It's actually an effect that's been elucidated over the last several decades. Well, first we know from the 1980s until now, there's been a really large number of epidemiological studies that have shown that people who take aspirin have a lower incidence of colorectal cancer. And for those of you who may be familiar with epidemiology, one of the key components of what makes a potential finding really potentially relevant is if you see the same effect in many different studies in many different populations. So now there have been several hundred studies that have been done in various populations and with different study designs that have all shown consistently that people who take aspirin have a lower incidence of developing colorectal cancer. Of course, epidemiological studies don't necessarily prove causality. So epidemiology is a science in where we look for associations, and sometimes those associations may be cause and effect. And to be able to understand whether something is truly causal, we need to be able to rely on clinical trials where we actually do experiments on populations of individuals by intervening with a specific agent and seeing whether it affects a particular clinical outcome. So it's sort of the highest tier of evidence for identifying whether something is a cause and effect relationship. And in the case of aspirin, there have now been 5 different randomized control trials where people have been randomized to aspirin versus a placebo or a sugar pill, and have shown that people who take aspirin have a lower risk of developing polyps, which are the widely known precursor for colorectal cancer. So people who develop these colon polyps, those polyps over time can become cancerous. And so clinical trials have been done that have actually shown that if you take aspirin, you have a lower incidence of developing these polyps. In addition, there have also been a large number of clinical trials that have been done of aspirin in the prevention of heart disease. And many of these studies have in turn been used to actually look at the effect of aspirin in these clinical trials on cancer outcomes by linking it to databases where we can understand whether people who are on the studies develop cancer, and also linkage with registries. And across many of these cardiovascular prevention studies, it's been very consistent that people on aspirin therapy during those trials long-term have a lower risk of developing cancer and dying from cancer. In addition, we have randomized trial evidence of aspirin in the setting of people that are genetically predisposed to cancer. Specifically, there's a genetic syndrome known as Lynch syndrome, where people have about a 70% lifetime risk of developing cancer because of a specific genetic mutation in their DNA. And in those individuals that were put on a clinical trial of aspirin, they also had a lower risk of developing cancer over the long term. And then finally, we have data from a large clinical trial of women that was conducted in the United States called the Women's Health Study. This is the largest clinical trial of aspirin prevention that's been done for cardiovascular disease and cancer. And what's been shown in that clinical trial is that women who were randomized to aspirin had, over a 10-year period, after 10 years of follow-up, a lower risk of developing cancer as well. So all of this data really has lended credence to the idea that aspirin not only can prevent heart problems, but also can prevent colorectal cancer. This strength of data led the U.S. Preventative Services Task Force, which is an independent group of experts, to review the evidence and come up with clinical recommendations for the use of aspirin for both heart disease prevention, and then also they added to the list of things that aspirin could prevent cancer. And this was really a milestone recommendation. So by the time this recommendation came out, there were very few, if any, examples of a medication being recommended to actually prevent cancer. So as a milestone in the field, in 2016, the U.S. Preventative Services Task Force actually recommended that low-dose aspirin be used for the prevention of heart disease, and colorectal cancer, particularly in certain age groups. And this really led the field to think about aspirin as a widespread population strategy for prevention. And this made a lot of important news, both in the medical field, but also in just the lay press. So certainly, for example, in the lay media, there was a lot of attention being paid to aspirin for prevention of cancer, and it became a very exciting strategy going forward. But then 2021, things changed, and this actually was a complete reversal of that recommendation by the same body called the U.S. Preventive Services Task Force, where they actually recommended against the use of aspirin for prevention of heart disease, for prevention of colorectal cancer mortality. So what I want to take you through is our understanding as to why this recommendation changed and how this actually has created some more opportunities for thinking about using aspirin in a more precise way. Of course, it led to confusion. So as you might imagine, the lay press also really didn't know how to handle this information compared to what was happening back in 2016. And the articles that came out really created some concern among the general public that we really didn't understand enough about aspirin and left a lot of people confused. So what's the origin of why the recommendation changed? And so I'm going to take you through the reason for the recommendation change and why really getting more into detail and depth into understanding this recommendation change gives us some insight into some of the differences in the biological effects of aspirin that may occur in people of different age groups. Specifically, I want to refer to a clinical trial known as the Aspirin study. This was a clinical trial of over 19,000 people in Australia and the United States who were put on a clinical trial in which they were randomized to either aspirin or placebo. And over about a 5-year period, they were followed for the incidence of developing either dementia or disability. And this was the sort of primary endpoint of the study. Within the Aspirin trial, there was also a look at whether the effect of aspirin on people on the trial had any impact on cancer-related death. And what was very, very surprising was that this trial actually showed a very different result from prior clinical trials. And for those of you who may be familiar with hazard ratios, which is the way we sort of think about clinical trial data, the hazard ratio for people who were randomized to aspirin was 1.31, meaning there was about a 30% increase in cancer mortality in people that were taking aspirin compared to people that were not taking aspirin. So this was a complete contrast to prior clinical trial data. So what was interesting, though, was that this was a finding that happened after only about 3 years of treatment. So people were actually getting this signal of increased cancer death after only 3 years of treatment, which was actually quite surprising for people in the field of cancer prevention. Because we think about cancer as something that actually grows over time. It's a relatively slow-growing process. We think cancers, particularly colorectal cancer, probably take at least 5 to 10 years to develop in a person. So to see an effect on cancer death after such a short intervention period was very, very confusing. So how do we explain these results, and why are they so different than prior clinical trial data? Well, the first explanation for why the difference might have been seen was that the Aspirin trial was not a trial designed to really test the incidence of cancer. Also, the treatment duration, i.e. 3 to 4 years of treatment, was actually very short, and maybe the follow-up was not long enough. And the last is maybe there's something different about when we use aspirin in an older population compared to when we use aspirin in a younger population. And maybe using aspirin when you're older, as this population used aspirin, was maybe an opportunity that was too late. So let's go through the first explanation, which is that it was not a test of cancer incidence. So obviously, the primary outcome they were looking at with respect to cancer was cancer-related mortality. Of course, you cannot die from cancer unless you first develop cancer. So it's important to understand, does aspirin actually affect the development of cancer, not just does aspirin affect death from cancer. So we were able to actually get into detail about this information when I started collaborating with the investigators in this study back in 2020. And what we looked at was the effect of aspirin treatment in the patients on the incidence of cancer, actually the development of cancer as opposed to death from cancer. And we actually found a very interesting result. There was actually no association of aspirin with developing cancer. So again, this is confusing because they showed this effect on cancer death, but not on cancer incidence. But what we did see was that there was an increase in the risk of developing late-stage cancer among aspirin users. Specifically, we call these stage 4 cancers, and also an increased risk of developing cancers that were metastatic or already spread throughout the body. So what does that actually suggest? Well, it suggests that maybe there is an effect of aspirin in people who maybe already had early cancer on the study. So maybe these people that were on the study were initially harboring small lesions or small cancers in their body before they were put on the treatment, and then when they were started the treatment, that aspirin may have caused a different effect and may have actually caused a cancer to accelerate and cause cancer-related death. In addition, I think we know that the effect of aspirin is established in preventing early lesions. So I show you again the clinical trial data, and there were 5 different randomized trials that showed people who take aspirin have about a 30% reduced risk of developing early stage polyps and earlier stage cancer. So the effect of aspirin on cancer may actually affect cancers early in development and may have a different effect later in development. What about another explanation? Well, the second major explanation was maybe the treatment duration was too short. So if we think again about aspirin and its effects biologically on cancer, we have to think about cancer as a slow-growing process, that it takes many years for people to develop a cancer, such as colorectal cancer. And the Aspirin trial was only a study that was conducted over about 4 years of treatment. And this would be supported by prior trial data. So I mentioned the Women's Health Study was a large clinical trial in which women were placed on aspirin for about a 10-year period. And the benefit of aspirin did not occur until people were treated for at least 10 years. So the Aspirin population only treated people for about 5 years, so probably the treatment duration was too short. In addition, this was also seen in the other study where there was an effect of aspirin. This is the Lynch study, people, again, with genetic predisposition to cancer. And in this particular population, people also needed to be treated for at least 10 years before you saw a benefit with respect to cancer incidence in the Lynch population. So the Aspirin trial was probably too late, and what this implies is that if we continue to follow the patients for a longer period of time, we may actually start to see a cancer benefit emerge after 10 years. And finally, I think this does raise concerns about whether the Aspirin population was selected in a different way than prior clinical trials. So many clinical trials of aspirin have been done in the past. And again, those trials did show a benefit with respect to cancer incidence, but those clinical trials were largely of people who were in their middle ages. So people that were in their 40s and 50s, maybe into their 60s. But there actually had never been a study of aspirin in people over the age of 70, which is what the Aspirin trial was focused on. And so maybe the fact is that this was the reason why there was a different effect. And why would that be? Well, is there a different biology in the way cancer is developed in older people versus young people? As you might imagine, across the age spectrum, the kinds of mutations that you develop in tumors in young people may be very different than the kinds of mutations you develop in older ages. So in the earlier stages of tumor development, when someone's younger, maybe aspirin has this ability to prevent those tumors from developing, but in later stages, it may be a different biological process by which those tumors develop, and aspirin may have a different effect, and maybe even a detrimental effect. And we actually wanted to prove this in other populations, so we looked at this in a separate population in which we had the ability to look not only at the effect of aspirin at older ages, but also the effect of aspirin when you start taking it at a younger age. And this was an epidemiological study we conducted in men and women enrolled into 2 large prospective population-based cohorts known as the Nurses' Health Study and the Health Professionals Follow-Up Study. And what we found is that on the right-hand side, you can see in this box, there was about a 30% lower risk of developing cancer if you started taking aspirin before the age of 70. But if you started taking aspirin after age 70, there was no benefit. And those are the 2 bars that you see on the left-hand side. So this was shown in a separate population that when you start taking the drug makes a difference. And you can imagine biologically that by the time you're 70, many of the mutational events that might occur in your body that lead to cancer may have already occurred. And so the horse is sort of out of the barn proverbially. And so you need to really start taking aspirin at an earlier phase in life to really start to see some of the cancer benefits. This was also demonstrated by results from another clinical trial. This was a study done in Japan known as the Japanese Prevention of Diabetes Complications Trial, In that population, you can see on the left-hand side, in people over the age of 60, there's no difference in the incidence of cancer in people who take aspirin versus not. On the right-hand side, though, you see that there is a difference in those two survival curves. So people who take aspirin are in blue, and they have a lower incidence of cancer compared to the people that don't take aspirin in red, if you're younger than 65. So age seems to make a difference, not just in the Aspirin study, but also in other clinical populations. So this, I think, does speak to the idea that aspirin can be a cancer preventive, but we have to think not only about taking it at an earlier age, but also taking it at a point in time biologically when it could make a biological difference. So now I want to move into some discussion about sort of cancer biomarkers. So the prior evidence suggests that we need to think about differences in biology in older adults versus younger adults, but maybe we can also think about biological differences that could be detected by using cancer-related biomarkers. So what is a biomarker? A biomarker is maybe some ability for us to predict whether you can or cannot benefit from aspirin. And this was considered to be a high priority in the field of cancer prevention. So the Lancet Oncology Commission came out with a statement that perhaps the most promising precision prevention strategy could be the use of aspirin, which is where we started to really focus our work. So thinking about that, how do we come up with biological biomarkers for prevention? Well, we need to understand about the biology about what's happening. We need to understand what is it that aspirin's doing biologically to prevent cancer in order for us to develop biomarkers. So we know that the way that aspirin actually works is potentially through preventing the production of prostaglandins. Prostaglandins are proteins that actually that are synthesized in the colon. And this schematic shows that aspirin actually inhibits the conversion of certain proteins called arachidonic acid into these prostaglandins. And if you actually use aspirin, you may block some of the enzymes that lead to the conversion of arachidonic acid to prostaglandins, and therefore aspirin may actually reduce the production of prostaglandins in your colon, thereby preventing cancer. So we wanted to see, is this actually the case in the setting of humans and aspirin? There have been a large number of animal studies or experimental studies to show this benefit. Can we actually prove it in a human population? So we did this study many years ago looking at the effect of aspirin on colorectal cancer when we actually look at some of the molecular pathways that exist in the cancer tissue. We actually analyze the cancer tissue for the expression of an enzyme that we know is important and blocked by aspirin therapy. And we showed in our study that there is about a 25% reduced risk. That relative risk of 0.73 you see on the right side is a relative risk of developing cancer here among regular users of aspirin compared to non-users. But actually, if you look at the effect of aspirin on cancers that are profiled by their molecular features, you see in particular that the effect of aspirin is greatest and actually significant only in those tumors where there's overexpression of a specific enzyme that we know is affected by aspirin treatment, which is the PTGS2 or the COX2 enzyme. So this shows that maybe aspirin affects those individuals for whom they're developing cancer on a pathway that is dependent on this particular enzyme and is dependent on the effect of prostaglandins on the colon. So what does this mean actually for developing biomarkers? Well, we actually also wanted to explore other biomarkers in this system. So we had this ability of aspirin to potentially block COX2, but also we did think about other enzymes in the chemical pathway that leads to the conversion of arachidonic acid to prostaglandins. This particular enzyme is 15-prostaglandin dehydrogenase. This enzyme is important because this enzyme here, COX2, is the principal accelerator on the process. It synthesizes prostaglandins, and 15-prostaglandin dehydrogenase does the opposite. It actually breaks down prostaglandins, so it's sort of the brake on the system. So you potentially need to also think about this enzyme being important in addition to the COX2 enzyme. So we embarked on a study in collaboration with a laboratory at Case Western Reserve University in the United States, Sandy Markowitz, to understand, does aspirin affect risk of colorectal cancer according to whether you express this enzyme or not in your normal colon? So we did this study. This was led by some postdocs in my lab, in which we showed, again, regular aspirin users had a relative risk of 0.73, or about a 30% reduced risk of developing cancer compared to non-users. But in particular, the benefit was seen among people that had intact levels of this enzyme in their colon. So about a 50% reduced risk of cancer in people that had an intact 15-prostaglandin dehydrogenase enzyme compared to those that did not. So creating another example of how we can use a molecular biomarker to risk stratify people for treatment. We also wanted to understand other potential biomarkers in this pathway. In particular, there is a urinary marker known as prostaglandin metabolites. You can measure prostaglandin metabolites in the urine of a person to know what's their overall level of prostaglandin tone. And does this also predict whether someone's going to respond to aspirin? We became interested in this enzyme because of other studies that were done in the field that actually showed, for example, that the urinary prostaglandin metabolite actually associated with future risk of developing cancer. So if you have an elevated level of these metabolites in your urine, you have about a 5-fold increased risk of developing colorectal cancer compared to people that had low levels of this metabolite. We followed this study up with our own study that found that people who have high levels of this urinary enzyme have about a 30-some% increased risk of developing colorectal polyps compared to those in the lowest level of the metabolite. In addition, we found that people who had high levels of the metabolite also responded better to aspirin than people who did not. So this, again, was a potential molecular biomarker. So to actually explore this further, we did our own clinical trial to know, does aspirin actually reduce levels of this biomarker? So this was a clinical trial we conducted at our hospital in Boston, where we randomized people with a prior polyp to either placebo, low-dose, or high-dose aspirin and examined, does this actually change urinary prostaglandins, and does it also affect other potential molecular biomarkers? And we did find that treating people with aspirin reduced the levels of urinary prostaglandin metabolites by about 30% in both low-dose aspirin users and high-dose aspirin users. So this is a potential effect of aspirin that is measurable through the use of this biomarker and allows us to think about this as a strategy for identifying who's at risk for developing polyps and cancer and who may stand to benefit more from the use of aspirin treatment. So now I want to shift gears into a little bit of a discussion of how can aspirin actually affect other cancers other than colorectal cancer. Specifically, how does aspirin maybe affect liver cancer, which is a growing cause of cancer-related death, both in the United States but across the world, and certainly a leading cause of cancer death here in Hong Kong. So we examined this within different data sets as well. So this was a study we conducted in Swedish registry data, and we found in people with chronic hepatitis B and chronic hepatitis C that they have, we know, a higher risk of developing a liver cancer over time. And in this population, we found that people who took aspirin, seen here in blue, compared to people that didn't use aspirin, had a lower risk of developing liver cancer with longer-term follow-up. So this potentially also represents a preventive strategy for a very difficult-to-treat cancer other than colorectal. And we also did a similar study in patients with non-alcoholic fatty liver disease, or something that we now call metabolic-associated steatotic liver disease, in which people who had this underlying liver condition also had a low risk of developing a liver cancer compared to people who were not taking aspirin, about a 50% reduced risk. So we wanted to know, is this a causal effect? And is this an effect that we can also use to develop molecular-based biomarkers? So Tracy Simon, who's also a gastroenterologist in my group, led this clinical trial study of the effect of aspirin in the treatment of metabolic dysfunction-associated steatohepatitis. And this is a condition where many of the harms of alcohol on the liver have been well documented. And it's known that alcohol can cause scarring of the liver or cirrhosis of the liver, and that's because of the development of fat deposits in the liver. But there are people who don't drink significant amounts of alcohol that also develop this condition and also may develop cirrhosis of the liver and also develop liver cancer. So we wanted to know how the effect of aspirin in this particular condition. And it's a very prevalent condition in the US. About 30% of US adults have metabolic-associated steatohepatitis. And again, if you have the steatohepatitis, over time, about 20% of people may develop fibrosis, another 20% may develop cirrhosis or scarring of the liver, and another 20% may develop liver cancer. So preventing or trying to reverse metabolic-associated steatohepatitis is a very important clinical priority. And at this point, there's really no FDA-approved therapy for metabolic-associated liver disease. So we also think that there is a potential role for aspirin in this condition because we know that aspirin actually has anti-inflammatory effects in the liver and also anti-tumor effects. There's both data in animals, but also there is data in human studies. So we decided to do a randomized trial of aspirin in metabolic-associated liver disease in our population in Boston. And we took adults between the ages of 18 and 70 who had established metabolic-associated liver disease and randomized them to either a sugar pill, placebo, or aspirin treatment. We randomized 80 people on the study. 40 were on aspirin and 40 were on placebo, and then completed the study over about a 6-month period to assess the effect of aspirin on biomarkers and measurements that we know are associated with metabolic liver disease. The primary endpoint of the study was the change in baseline to 6-month liver fat as measured by a radiological procedure known as magnetic resonance spectroscopy. We also did a variety of secondary endpoints looking at MRI proton density fat and other radiologic measures. And these are the results of our study, which we recently presented at the liver meetings in 2023 and will be published next month in March as a full clinical study. And what we found was that aspirin actually did effectively reduce liver fat in a very good way. So specifically, the aspirin group is here in blue, had a significantly reduced amount of liver fat after 6 months of aspirin treatment compared to those that were on placebo. There's also a difference in the primary endpoint. And compared to placebo, there's about a 10% reduction in liver fat in people treated with aspirin compared to those that were not. In addition, in secondary endpoints, we also showed a decrease in relative change in liver fat in the aspirin-treated group compared to those, compared to those in the placebo arm, the aspirin arm compared to the placebo arm also had a decrease in many of the secondary endpoints. So there is a benefit of aspirin in this particular condition, which could also explain why we're seeing the longer-term benefit in the epidemiological studies on liver cancer. I do also want to mention that there's a potential other use for aspirin in the prevention of cancer of the esophagus. This is a clinical trial known as ASPECT, in which patients were treated with something called a proton pump inhibitor, which is a acid-reducing medicine plus aspirin. And the people that were on both medicines here, seen in the purple, had a lower risk of developing esophageal cancer over time. So there's also a potential benefit of aspirin, not only in colorectal cancer, but liver cancer and also now esophageal cancer. And then finally, I do want to leave you with some discussion of the effect of aspirin on bleeding. So one of the major reasons for why people are cautious about using aspirin is that aspirin also may cause gastrointestinal bleeding, and that's been something that's been documented across many clinical trials that have been done over the years. In particular, it's felt to be a cause of peptic ulcer disease or ulceration of the stomach, which can lead to bleeding. But this is actually also an evolving story as well. There's now, I think, more and more of an understanding of that, of peptic ulcer disease and more options for prevention. And also, we're seeing actually a secular decline in the incidence of peptic ulcer disease, at least in European populations. Whether that also holds true for populations like Hong Kong, I think, remains to be seen. But I want to point you to the results of a recent study called the HEAT trial. This is a study of something called a Helicobacter pylori treatment in patients with aspirin. Now, Helicobacter pylori is a bacteria that's known to cause ulcers, and it's felt that it is one of the reasons why people develop ulcers. And when you combine that with aspirin, that potentially magnifies your risk of developing an ulcer when you're on aspirin treatment. So there is a need to know, is treating people for Helicobacter pylori a strategy to prevent ulcer disease? So this was a large clinical trial that was done of Helicobacter pylori treatment done in the United Kingdom to examine if you treat people for this bacteria, do you reduce their risk of developing ulcer-related bleeding? And they did show in this trial that there was an effect, indeed, of people who were treated for Helicobacter pylori compared to those that were not. So people in the blue had Helicobacter pylori treatment. Those on the red did not. And they had less risk of developing aspirin-associated bleeding compared to those that were not eradicated. But what was really, I think, quite profound here was that this was a study of over 5,000 people, so a very large population of people. And among 5,000 people, and these are all people that were taking aspirin regularly, you actually only had 40-some events of bleeding, only 40-plus events of peptic ulcer bleeding. So it's actually a very rare event happening in contemporary populations. And if you actually look at this in the setting of what we consider to be ways of looking at absolute levels of data, you can see that there's it's very hard to actually see any difference in the absolute risk of developing a peptic ulcer on aspirin treatment when you have such a small number of events. So the fact is that the effect of aspirin on ulcers and bleeding may actually be quite lower than we actually anticipated. And so this led the authors of this study to actually be very clear about the fact that there is a very low background rate of ulcer bleeding in contemporary clinical populations, and that as a result, we should rethink about whether aspirin treatment makes sense in a larger number of people, because maybe in contemporary populations, the risk of aspirin-associated ulcer bleeding is quite low and lower than we had previously considered. So in summary, I want to emphasize that what we are understanding about aspirin is that there is a strong evidence base that aspirin can prevent colorectal cancer, but new trial data, specifically trials of aspirin in older adults, specifically people over the age of 70, suggest that we need to think about aspirin according to the age of the population and when during the life course we actually start to treat people with aspirin. There is a need for developing biomarkers to understand who will benefit more from aspirin compared to those who will not. In addition, there's emerging data that aspirin can prevent other cancer types, not just colorectal cancer, but now liver cancer and also esophageal cancer. And these are 3 leading causes of cancer death around the world, and also 3 causes of cancer that are very, very difficult to manage when they're diagnosed late. So being able to identify a preventive strategy for prevention of these cancers, I think, will be an important clinical imperative going forward. We know the benefits, though, of aspirin treatment need to be considered against the risk of GI bleeding, but GI bleeding may actually be something that's actually overemphasized in current aspirin-related guidelines and may actually be diminishing in incidence. And the last point is that when we think about cancer prevention or prevention of any disease in the future, we're leaning now towards more of a paradigm of precision prevention, trying to understand who is it that actually stands to benefit more from a treatment and actually has a lower risk of developing side effects from a preventive intervention. It may be more challenging in the future to come up with sort of one-size-fits-all strategies for prevention because of concerns about being able to balance risk and benefits. And as we have more of an understanding of people's genetic risks or other biomarker-related outcomes for incidence, we can start to understand more about using these biomarkers for cancer prevention. And so again, I want to go back to the principle that we need to identify ways of prevention that are cost-effective, easy to employ across a large population, and aspirin, I think, does represent a potentially very attractive option down the road. So with that, I do want to recognize many of the people in my group for whom this research would not have been possible, and also thank, of course, collaborators that I've listed here, as well as acknowledge the participants in our studies, specifically participants in our epidemiological studies, but also the clinical trials that we've been able to be a part of over the last several years. And with that, again, I want to thank you for your attention. And again, I'm very happy to join Professor Wong in a question and answer period. But thank you very much.
Thank you, Professor Chan, for your educational and insightful talk. Please be seated on stage. I am sure that there will be some questions from the floor, so may I now invite Professor Wong, moderator of today's lecture, to come up on stage and host a Q&A session for us. Professor Wong, please.
Okay, thank you very much. I'm sure everybody will consider this as a very outstanding, insightful, and also very inspiring lecture. So let's have a great round of applause to Professor Chan, please. Thank you so much. So now we understand that, in fact, the use of aspirin is associated with low risk of cardiovascular disease, different types of cancer, colorectal cancer, liver cancer, and probably the other cancers which have not yet been explored. So, well, I think it's actually question and answer time. But then usually the moderator have the privilege to ask the first question. So the first question is, well, do you think there's any ethnic differences? Because, I mean, in my general outpatient clinic, when I see a patient with high risk of cancer, well, no matter it's liver cancer or colorectal cancer, I share the same feeling of hesitation to prescribe aspirin to Chinese individuals because they have relatively higher risk of gastrointestinal bleeding, which might be a little bit different from the studies which employed Western population. So what do you think? Should I medicalize everybody at high risk of colorectal cancer using aspirin? So almost everybody's taking aspirin above the age of 50. So what do you think?
That's a great question, and one I know that we reflected on earlier. The vast majority of clinical trials of aspirin have been done in European populations. There have been studies of aspirin for cancer prevention in Asian populations. There, in particular, are clinical trials of aspirin in Japan. And one of the studies that I showed on that slide was conducted in a Japanese population, and they also showed a reduction in risk of developing colon polyps, which is the precursor lesion to the vast majority of colorectal cancer. And they also had, some data on sort of incidence of complications like bleeding, and actually found that it was also relatively low. So I think there is this sort of prevailing theory that, or conception that aspirin may have a greater risk of bleeding in Asian populations, but I think that still remains to be tested vigorously. I think there needs to be more clinical studies done to actually show whether that is a true effect and a true difference in terms of racial ethnic differences in aspirin bleeding, and also whether that may have also changed over time, because I think we're starting to see more and more that there are secular trends in declining incidence of bleeding in Europe, European populations in the US, that may also be happening in Asia. And then there also are, clear data from Hong Kong populations. In particular, I think you and I spoke about the Hong Kong general practice databases, which are available for research. There have been studies done of aspirin in those databases that also show that the aspirin users in the Hong Kong population also have a lower incidence of cancer, colorectal cancer as well. So I think there's a lot of supporting evidence that suggests that there are more similarities and differences in the benefit-risk ratio of aspirin in Asian populations with American or European populations. So I think future studies really need to be done to focus on that.
Yes. Thank you very much. I do wish to substantiate on this point, because I think several years later, probably almost a decade ago, the American Cancer Society has a simulation study recommending people aged 45 instead of 50 to receive colorectal cancer screening. So does that mean that the age of prescribing aspirin should probably be also lower to tailor to the changing risks of colorectal cancer among the younger individuals?
Yeah, that's a very good point. So one thing I didn't have a chance to cover today is this sort of alarming increase in incidence of colorectal cancer in younger adults. So colorectal cancer has traditionally been considered a cancer of older adults, meaning people over the age of 50, which is why screening guidelines in most parts of the world, including the US, traditionally had focused on cancer screening in people over the age of 50. But since the 1990s in the US, and then now across populations in Europe and now in Asia, we're seeing that the steepest rise in incidence are occurring in people younger than 50. And that's a population that we are not screening. This did lead the American Cancer Society and the U.S. Preventive Services Task Force to lower the screening age. So now we screen people over the age of 45 in the U.S. But that's not the complete solution because, as you know, screening is expensive, and we also see a rising incidence of cancer in people younger than 45, and we're not going to be able to screen our way out of that. I think we have to think about preventive interventions in a younger population that don't depend on screening. And I think a drug like aspirin is potentially very attractive because bleeding from aspirin is also age-related. So your risk of bleeding is actually much higher when you're older than when you're younger. So if we're able to use aspirin in younger adults, we might have a really good risk-benefit trade-off. These are people that are maybe at higher risk of cancer now for unclear reasons, but also very low risk of side effects from bleeding. So this may be a population that is particularly good for treatment. And one answer to the question also is this also a possibility where we could treat people with aspirin for a short period of time, 10, 20 years, and then maybe stop using it when they become older so that you can sort of treat people during the period of high susceptibility to cancer and lowest risk of side effects, and then when they're older, when you sort of hopefully avoided some of these mutational events that happen because of aspirin, you may be able to stop treatment when they're at higher risk of having complications.
Okay, thank you very much. I do think this highlights one of the very important points you've made at your summary slide, where we should have precision medicine and also individualize decision. So in family practice, we usually have shared decision-making processes with our patients. So that's a very important part as well. Thanks for the very, very great reminder. So let's have a look at whether we've got any questions from the floor. I'm sure our students and also our colleagues will be very interested in this topic. So let's have a look and see any questions from, all right. Okay, I may have your hands up, please. Our colleagues would actually pass you a microphone for this. So is that only one question, right? Okay. Okay,
hello.
please. Thank
I have
you.
a question about the concept of prevention of cancer. Is it for someone who's already diagnosed and are in the early stages of cancer, or is it for someone who's not diagnosed? Or, like, I just don't get the general concept. Like, who would be like the patient who would get aspirin for their prescription?
So your question is like, what group of patients to treat, you mean?
Yes, correct, because like it's called prevention of cancer, but if they're in perhaps like the early stages of cancer, could they still be treated with aspirin?
I see, yes. So that's a really good question. So the question is aspirin just for prevention of developing cancer? Would it potentially have a role for treatment or people who already developed cancer? So that's another area our lab works in. We've been interested in potentially using aspirin in people that were previously diagnosed with cancer, in particular people who, for example, have colon cancer, have surgery, have that cancer removed, and want to reduce their risk of developing a recurrence down the road or improve their survival down the road. And it's a particularly attractive option because people who have colon cancer still have a pretty significant risk of recurrence even after surgery. So finding ways to prevent future cancer is a high priority, and this is also a group of patients for whom, again, the risk-benefit calculus may work in their favor because their risk of recurrence is high enough that they want to do whatever they can to prevent it from coming back. So we've done some epidemiological studies, and we did show in some of our epidemiological studies that people who take aspirin after colon cancer diagnosis have about a 30% reduced risk of recurrence and death from colorectal cancer. And this has led to the development of multiple clinical trials that are being conducted around the world to examine this question in clinical trial populations. There have been studies in Europe, but also one study that was just completed in Asia that are underway. The Asia study showed a trend toward a benefit, so they showed that there was a non-significant decrease in risk of developing recurrence and in people who were treated with aspirin. and a trend toward improvement in survival. But it was sort of underpowered in terms of this, meaning the study was maybe not big enough to show an effect. So we're waiting for the results of additional clinical trials, and then there's also an effort to combine all those trials together to get a large enough population to really potentially see a benefit, because that could really transform the care of patients who have already developed cancer.
Thanks a lot, Professor Chan. I think that's, well, very, very clear and very reasonable answer. So let's see if we've got any further questions. There's one
Hi,
here.
thank you for your talk today. I just want to ask, what are any other major side effects of using aspirin when you're using it for prevention of cancer for a normal individual aged around 45 to 50, especially any maybe psychological effects apart from GI bleeding, like any major side effects?
Yeah, great question. So bleeding is the most common adverse side effect. There also is sort of gastrointestinal intolerance of aspirin with sort of non-specific complaints of abdominal pain and things like that, which are not related to bleeding and not related to ulcers. So that's a pretty common side effect as well. And unfortunately, many of those patients are just never really able to tolerate it because they get symptoms, GI upset. There's not really any established psychological side effects of aspirin treatment. I think the most feared complication of aspirin treatment is bleeding in the brain, so developing, for example, an intracerebral bleed. But that's very, very rare. That's a very, very rare complication of aspirin. So one that we see very, very rarely in clinical practice, and but one also that we speak to our patients about. So in terms of common side effects, it's really sort of gastrointestinal primarily, and less so neurologic or definitely no reports that I know of psychiatric problems.
Okay, thanks again to Professor Chan. So any further questions from the floor? Okay, there's one from Professor Fung, our former head of the United College, also an expert in this area. Professor Fung, please.
Professor Chen, thank you very much for the very interesting lecture. I'm not a physician, so I want to ask in layman's terms. I understand that aspirin can prevent the metabolic disease-related fatty liver, but in Hong Kong, many people drink alcohol. So can you tell us whether aspirin can also reduce the incidence of alcohol-induced fatty liver?
That's an excellent question. We don't really know the answer because that's never really been studied in any detail. Some of the effects of aspirin potentially may be, some of the biological effects of aspirin may have a role in alcoholic liver disease. Alcoholic liver disease probably operates also by the effect of alcohol on inflammation in the liver and also depositing fat in the liver. So you can imagine that there might be also a potential role for aspirin in preventing some of those downstream effects and preventing alcoholic liver disease from progressing. But it really hasn't been studied, and I think that's largely because it's a difficult population of patients to certainly study in a clinical trial. And there's not been a lot of epidemiological studies that have looked at this question. Again, largely because people who drink a lot of alcohol or have alcoholic cirrhosis and liver disease are often patients that are not taking aspirin or not under good medical care in general. So it's difficult to do those kind of epidemiological studies. But I think it's certainly an area worth investigating in more detail.
Thanks a lot once again. Yes, one from Professor Mong, please.
Thank you so much, Professor Chan. Wonderful lecture. So I work on artificial intelligence and big data analytics, and I wonder if you have any new efforts in place where you're using big data technologies to help investigate various factors attributing to cancer. Thank you.
No, I think it's a very pertinent point, because as you are aware, and certainly we're aware in sort of my area of medicine, AI is transforming the way we think about medical care. It's also transforming the way we think about cancer prevention. And that's largely because we're able to now use large amounts of data to help us to understand some of these areas that took us many, many years to be able to gather data to study. For example, can we use clinical data and clinical information to identify and better risk stratify people for cancer preventive interventions? So AI will be helpful in that circumstance in terms of culling together clinical data to identify maybe predictive algorithms of cancer risk. It's also very important now to think about AI as a strategy for processing large amounts of biomarker-related data. Some of that data is what we call omic data, genetic data, molecular profiling data, and sequence data that come from profiling people's DNA. Also, as you may know, a lot of sort of cancer screening interventions are dependent on imaging. And so AI is very important now for image processing and being able to more efficiently process large amounts of imaging data to help identify cancer risk in patients that are undergoing imaging studies. So there's all sorts of ways that I think AI will really transform prevention of cancer in many of the same ways that AI, I think, will transform clinical medicine more broadly.
Okay, thank you very much. So it sounds to me that, Professor Chan, aspirin is very affordable, it has very little side effect, it's very effective in prevention of cardiovascular disease and different types of cancer, and probably also liver cancer as well as fatty liver diseases. So what's the status of aspirin recommendation in the United States? Is the evidence, it sounds to me that the evidence is very, very strong that we should actually prescribe aspirin for people aged, say, 50 to 70. How come this doesn't sound to be very much implemented in the general population, or what's the biggest barrier for this to be implemented?
Yeah, I think that's a very good question. I do think that we were probably in a situation where the recent clinical trials, particularly Aspirin, I think set the field back, because I think the results of that study, showing this potential increased risk of cancer death in older populations, was interpreted to mean that aspirin was potentially harmful for everybody. But as I tried to explain in the talk, and what I think people are now getting a better appreciation of, is that it's probably not an effect that is seen across clinical populations. It may be an effect that's seen very specifically in older people. So reinterpreting that trial data, I think, will be necessary for people to feel comfortable about using aspirin in younger populations. I think we also face obstacles with respect to a general sense of there's not a lot of either political, economic, or pharmaceutical pressure to think about aspirin as a preventive intervention because it's so inexpensive. There's not, for example, a pharmaceutical company that's aggressively promoting it as a treatment or preventive option. So absent that, it's very difficult to cut through a lot of the noise that clinicians are facing in their everyday practice. As a family practice doctor, you know that doctors have very limited time with patients. And so it's just not been on their high list of priorities to have that discussion of shared decision-making about something like aspirin. They have so many other things to think about. So I think until we get more attention from the clinical community and more of a push from insurers and policymakers that this is a potentially low-cost option for prevention, and for clinicians and patients to be incentivized to use it, I think it's going to require more of that before we really can sort of overcome some of the barriers. at least in the US health system. I don't know whether that's true here as well.
Yeah, thanks very much, Professor Chan. I think it's a very timely reminder for both the physicians, policymakers, and general population. I'm sure everybody agrees with me that this lecture is actually very inspiring, with very fruitful discussion. So once again, may we now invite the audience to thank Professor Chan sincerely in our usual way. Thank you very much, Professor Chan.
Thank you.